Your breasts might kill you. This video might save your life. I got my first bra when I was 11. It was a training bra, and I remember thinking that it felt so odd to call it that, as if it were like learning to ride a bike. Does having boobs really require training? A lot of being a woman seems to, at least when it comes to our bodies, like shaving your legs for the first time, or finding creative ways to hide a tampon. So, does having breasts really require training? Yes. There is the unsettling truth that your breasts might try to kill you. Actually, breast cancer can kill you, not your breasts. Your breasts are great. So, who's at risk for breast cancer? Every single woman is at risk, and a small number of men. You don't need a family history to be at risk. 75% of new breast cancer cases have no family history. You can be a good person and do all the right things, like never smoke, run every morning, eat celery on your lunch break, only drink in moderation, take in every stray animal, remember all your friends' birthdays without the help of Facebook, and still get breast cancer. That's because being a woman is the #1 risk factor for getting breast cancer. I know, this feels like losing some cosmic bad luck lottery. Well, the good news is that even though breast cancer may push us around, we can push back. Breast cancer can grow, which means at some point it's very small. If you find breast cancer early, you have a 95% chance of beating it. If you wait till it's full grown, your chances of beating it drop dramatically. That's why the best thing you can do to beat breast cancer is to find it early. How do you find it? You have to look for it. That means every woman get your mammogram every year starting at 40. Period. Regardless of all the mixed messages out there about when to get screened and how often. Every woman, every year, starting at 40. This is a good starting point because every woman is at risk, but some women are more at risk, which is why it's so important for you to know your personal risk factors like your family history, your genetics, your breast density. 40% of women have dense breasts. Not those kind, these kind. Dense breasts make it much more likely that you will get breast cancer. The tissue looks cloudy on a mammogram, making the cancer hiding inside harder to find, which is why women with dense breasts need extra screenings like an ultrasound. It's not just for babies. There is no one-size-fits-all for breast cancer screening, kind of like how there isn't just one kind of lipstick for every woman. You need a personalized approach. So do you know your risk factors? Are you high risk or average risk? I said this video could save your life. That's not really true either. It's just a video. Early detection can save your life. So right now is the time when you make an appointment. I'm not kidding. Do it right now. Yes, you. Write it down. Set a reminder.
Hey Siri.
Do a painting or tie a knot. Know your risks. Ask for personalized screening. Get your mammogram every year at 40 and share this video with someone you love.
Good evening, everyone. My name is Ebony Richards, and I am a member of Zeta Phi Beta Sorority Incorporated, Pi Zeta Zeta chapter, the profound Pi Zeta Zeta chapter. And I just want to welcome each and every one of you to this very important conversation of breast care health. And joining me tonight is our moderator for the evening, Ms. Andrea Wolf. Andrea is the CEO of the BRIM Foundation to Defeat Breast Cancer. In this role, she works to maximize every woman's chances of catching an early curable breast cancer. Since assuming this position in 2015, Andrea has significantly expanded the BRIM Foundation's reach by improving its digital presence and website, expanding programs for medically underserved people in the DC area, and giving more low-income women access to breast diagnostic tests. Prior to assuming this role, Andrea served as the Director of Public Policies for Girls Incorporated, a national education nonprofit for low-income girls. In that role, Andrea lobbied Congress and the Obama administration to pass key domestic violence legislation focusing on violence against younger girls and teens. She also lobbied to improve access to STEM and financial literacy education for girls, to provide accurate sexual health education for girls, and to curtail substance abuse among teen girls. In 2016, Andrea was chosen as one of 10 women to watch by Jewish Women International for her breast cancer awareness work. Andrea graduated summa cum laude from the University of Pennsylvania and received her JD from George Washington University Law School. Please help me welcome our moderator for this evening, Andrea Wolf.
Hi, thank you so much, Ebony. I am thrilled to be here tonight with you and with the Zeta Phi Beta Sorority Inc. Pi Zeta Zeta chapter. It's an honor to be here for a number of reasons, but I've heard such great things about you all. I don't know if everybody realizes, but we're East Coast and you're West Coast, so you are a nice foray for the Brem Foundation to head over west, which is neat for us. So thank you so much. I am here tonight, as you said, as the CEO of the Brem Foundation to Defeat Breast Cancer. You all will hear so much more about us and what we do in a moment. But I am honored to introduce to you Dr. Rachel Brem. Before I get into all of her credentials, I will tell you and spare you the suspense that Dr. Brem is my mother. And so doing this work together with her, it has been a real honor and pleasure. Dr. Brem is the Director of Breast Imaging and Intervention at the George Washington University Medical Center. She's Professor of Radiology and Vice Chairman of the Department of Radiology and the Chief Medical Advisor at the Brem Foundation. Dr. Brem has served as the Brem Foundation's Chief Medical Officer and inspiration since its inception in 2006. She's a fellow of the American College of Radiology and the Society of Breast Imaging. Dr. Brem is the recipient of countless awards, including Castle Connolly Best Doctors and Best Cancer Doctor in the US. In 2015, Dr. Brem was ranked as one of the top cancer doctors in the US by Newsweek magazine. In addition, Dr. Brem has been instrumental in developing new technologies for earlier breast cancer detection, including taking 2 new breast imaging technologies through FDA approval, which are now widely used clinically. She has published over 140 peer-reviewed manuscripts as a result of her seminal contributions. She has lectured widely, both nationally and internationally. Dr. Brem received her BA in biology from Brandeis University and graduated with honors from Columbia University Medical School. Dr. Brem completed her diagnostic radiology residency and breast imaging fellowship at the Johns Hopkins Medical Institution. In addition to her clinical and academic accomplishments, which as you heard are many, Dr. Brem is a zealous advocate for early detection and has dedicated her career to finding effective and innovative ways to increase breast cancer prevention and early detection. Hi.
Thank you so much, Andrea. That was an extensive and wonderful introduction. I just want to thank Ebony and the incredible women on this event this evening for your interest in breast health and for joining us this evening. Thank you.
So, Dr. Brem, Mom, I want to start with a question about what you've done and how you can help others through that. You're a trailblazer in early detection of breast cancer, even being called a cancer detective by Dr. Oz. Can you tell us your story and how you chose radiology and breast imaging as the way to make a difference in women's lives?
Absolutely. So everybody is touched by breast cancer. Everybody has a breast cancer journey, even if you are spared breast cancer. But mine started at the age of 12 when my 37-year-old beautiful, vivacious mother disappeared. And it was only months later that we found out that our mother had breast cancer and was told that she had 6 months to live. Fast forward, the good news is that she lived 44 years and actually died cancer-free. So it was very important at that point. I was really impacted by the opportunity to have people survive by early detection. I then went on to college and medical school, and I was a medical student at Columbia. And at that time, New York was the epicenter of the use of mammography. And it was the first time that we showed that mammography really saves lives, that women that had mammograms died far less frequently than women who did not. So I thought to myself, gee, that's really the bandwagon that I want to get on. I really want to help other women so that no other young girl would have to go through what our family went through. And so I pursued radiology and then breast imaging. And as chance would have it, I became the director of breast imaging at Johns Hopkins, and one evening was charged with trying to find ultrasound equipment to buy. So I decided that what I would do is I would ask all the vendors to bring the ultrasound equipment in, and after the day's work, I would try the ultrasound equipment on myself and see which one had the best image quality, and we would get that one. So two things happened that night. One is that certainly figured out which ultrasound equipment to get, and the second is that I found my own breast cancer. So here I am, 37 years old, with 3 young daughters, and a breast cancer doctor with a new diagnosis of breast cancer. So I went on to have bilateral mastectomies. And I went on to have chemotherapy. And yet again, a second generation of here I am 24 years later, and gratefully cancer-free. But it also gave me the opportunity to understand what my patients were going through and give me that insight. But my cancer journey started as a 12-year-old girl and resulted in my passion to help women with breast cancer be part of every fiber of my being.
Thank you. And I personally am also honored to be part of that story. And I'll finish it up for you, which is that my mom, Dr. Brem, has 3 daughters of her own. And one of the reasons I'm here today is because I had prophylactic mastectomies when I was 30 because I didn't want to have the narrative continue in our family where all the women get breast cancer in their 30s. The joke continues because I have 4 daughters of my own, my mother's grandchildren. So this is a real passion for us, and it's a real close to home issue. And so I have to imagine that in a group of, women like yourselves, most of you have also been personally touched by breast cancer in different ways, but nonetheless, something brought you here tonight, and we are happy to be on this journey with you. Thank you for personalizing tonight's information. So you talk a lot about risk-based screening, and you saw the video that emphasized personalized screening. Dr. Brem, what does that really mean, and what do you most want women to know before speaking to their doctors about breast care?
So I think women need to understand that finding early breast cancer is critical for 2 reasons. One is that, as you saw in the video, 95% of women with early breast cancer beat the disease. And we are committed to doing everything we can to maximize the number of women who are, if they do get breast cancer, in that category, and the opportunity for women to have early breast cancer diagnosed. But it's very important to understand that it's not a one-size-fits-all solution anymore. Now, we have to realize that the progress that we've made with death from breast cancer is extraordinary. Over the past 20 years, the death rate from breast cancer has gone down 40%, an extraordinary number. But we still lose over 45,000 women in the United States to breast cancer every year. So we still have a long way to go. So what can we do? We have to have risk-based screening. And that means that you have to be empowered and informed about yourself and those that you love to get the best screening that you can. But before we talk about risk-based screening, we have to talk about mammography screening. And the reason that's so is because you've heard so much in the media about different recommendations from various organizations for when you should get breast cancer screening, when you should get a mammogram. And in fact, you might have heard something different from your doctors. But the most important thing that you need to know today is that if you have no other risk factors, you need to get a mammogram every year starting at the age of 40. Now, but you may say to me, the United States Preventative Services Task Force says I should start at 50 and go every other year. Or the American College of Family Physicians says I should start at 50 and have a mammogram every other year. Or even the American Cancer Society that says a woman should have the option to start at 40, but should definitely start at 45, every year to 55, and then every 1 to 2 years after that. And there's so many different recommendations. But what everybody agrees with is that if you start at the age of 40 and get a mammogram every year, the most women's lives will be saved. So how can that be, right? Well, the United States Preventative Services Task Force says start at 50 and get a mammogram every other year. And if you do that, we will maintain 88% of the reduction in mortality that we have. Now, raise your hand if you're okay to be part of that 12% that loses their lives as a result of less frequent screening. They agree, the American Cancer Society agreed, the American College of Family Physicians agree. Everybody agrees that more lives will be saved if you get a mammogram every year starting at the age of 40. And so let me just say back, you're probably thinking to yourself, why is it then that people why isn't there uniform recommendation of getting a mammogram every year at the age of 40? And the answer is that mammography has harms. The number one harm is anxiety that women feel when they get what's called a false positive mammogram, meaning that you go to get your screening mammogram and you may get called back to get additional views to clarify some breast tissue. And I can assure you, as someone who's been taking care of women with breast cancer for over 30 years, that if you tell someone that they have metastatic incurable breast cancer, they are far more anxious than if you tell them that they need to come back for another mammogram. And two things about that. One is there have been excellent studies that have shown that that anxiety that results from being asked to come back for additional mammography is transient. There's no lasting effect. But the worst part for that is that, and I know that the empowered and strong women that are part of your sorority, and particularly the chapter that Ebony showed us in just a few minutes before, you're so proud of, is strong women. And don't you think that we should have the right to decide if we want to be anxious, if we want to optimize our opportunity to get early curable breast cancer, even if it means going back for a second mammogram? But instead, I feel like sometimes like I'm living in the Middle Ages, don't worry your little head, women, that you're going to be anxious if you get called back for another mammogram. That is outrageous. So get a mammogram every year, starting at the age of 40. Now, back to risk factors. There are a number of risk factors that you really need to know about. And why is that? Well, because it will impact the kind of breast cancer screening you get to optimize early curable breast cancer. So you heard, usually if we don't start with the video, I say, well, what do you think the number one risk factor for breast cancer is? And often people say to me, family history, or even a previous history of breast cancer. The answer is being a woman. 75% of women, 3/4 of women who have breast cancer have no family history and no other risk factor except being a woman. So every day at work, I have, professors at GW, George Washington University, where I work, that I have the sad responsibility to tell them they have breast cancer. And they say to me, how can I have breast cancer? I go to the gym every day. I'm a vegetarian. I don't have hypertension. I'm the picture of health. And the answer is there is nothing that anybody can do that I can tell them you will prevent breast cancer. So what do you need to know to optimize the diagnosis of early curable breast cancer? One thing is family history. That's very important. Even though 3/4 of women who have breast cancer don't have the family history, if you do have family history, your risk is higher. So there are two kinds of family histories. One are genetic and one is familial breast cancer. Genetic is where certain women, and in certain populations of women it's much more frequent, have a mutation that's called a mutation in a tumor suppressor gene, so that if a cancer cell does occur in people's body, a woman's body, and it can, the cleanup mechanism to prevent it from growing is malfunctioning. And so they have breast cancer at a much higher rate. And you can get that gene from your mother as well as your father. So about 5 to 10% of breast cancers are genetic breast cancers. And women who have these genes can have a very high risk of developing breast cancer, up to 80% lifetime risk. So that's important. There are also families that don't have genetic mutations that have a higher risk of breast cancer. And it may be one of two things. It may be a gene that's as yet undescribed, or it may be that the whole family grew up on a landfill, was exposed to carcinogens or some other carcinogens in their family, and that can cause the breast cancer. The next thing that I really want to talk about is something called breast density, and that's really important. So what is breast density and why is it so important? Well, breast density is how white your breast tissue is on a mammogram. You can't feel it, you can't see it except on a mammogram. It is only, you can be perky dense, you can be saggy dense. You really can't tell except on a mammogram. Now, on a mammogram, dense breast tissue is white and breast cancer is white. And so if you imagine looking at a cloud-filled sky, you can't really see contrast between one cloud and the other. And the same thing is true of cancer in women with dense breast. We don't have the surrounding non-dense tissue to give us that contrast so we can see these cancers. And we know that the ability to find cancers on a mammogram in women with dense breast tissue is much lower. But that isn't the end of the story. Women who have dense breast tissue have a 4 to 6-fold increased risk of developing breast cancer. So it's the perfect storm. Harder to see on a mammogram, much higher risk of breast cancer. So the reason that's important is because you have to be armed with that information to know what else you can do. But you may say to me, but how important is that? I'll bet you very few women have dense breast tissue. The answer is that is not true. 40% of American women have dense breast tissue. And we know that using additional screening like ultrasound can find these hidden cancers. And they're really important cancers. And what I mean by that is that they're small, early, invasive breast cancers that haven't involved the nodes yet. These are exactly the cancers we need to find because they're potentially killer cancers if they get bigger, larger, and get out of the breast. So we have to use, so if you have dense breasts, you have to insist on getting an ultrasound in addition. We know that we can find 25% more breast cancers. And in fact, you heard Andrea mention, but there are now 36 states in the District of Columbia that have laws, and there is a federal law that has been passed as well that will require women to be told what their breast density is, because you need to be powered with that information to insist on getting that additional ultrasound. And in DC and in 7 other places in the country, we have we proudly, the Brem Foundation proudly was instrumental in passing the legislation that requires insurance to cover these additional screenings. So it's very important. And then you may have an even higher risk. You may have had a biopsy that showed atypia. There's some women who have had previous radiation therapy to their chest for things like Hodgkin's disease as a teenager. There are other conditions that put you at much higher risk. So why is this important? Well, if you don't have dense breasts and you don't have other risk factors, a mammogram is a very effective tool at finding breast cancer. If you do have dense breasts, then you must insist on getting ultrasound because we can find these important killer cancers that are hiding. And finally, if you have even a higher risk to that than that, then we have other technologies like molecular breast imaging, magnetic resonance imaging, MRI, that we can use to find these cancers in higher risk women. So that's why risk-based screening is very, very important. I should say that there are also other things that change your risk. Lifestyle, you actually can make a difference. So women who are obese have a higher risk of breast cancer. Women who have a high alcohol intake, high red meat diet intake have a higher risk of breast cancer. And women who are on hormone replacement therapy. So not everything is genetic or out of your control. There are some things that are in your control, but you have to remember that you have to screen based on risk for those things that are in your control and for those things that are not in your control.
Thank you so much. Could you talk for a moment about the different recommendations for screening ages and how some confusing information is coming out of different organizations, many of whom are actually widely respected? Can you clarify some of that for us, please?
Sure. So we talked a little bit about that, but some of the recommendations, like the American Cancer Society, recommend that you start, if you want, you start at 40. Every woman should start at 45 every year, and then every 1 to 2 years after 55. The United States Preventative Services Task Force, or the USPSTF, says start at 50 every other year until the age of 74. Now, we know that the risk of breast cancer increases as you get older. It's just that there isn't studies that have looked at the impact of screening mammography on older women. But we do know that mammography is important to get until you have if your life expectancy is less than 5 years, then we don't recommend screening mammography. Less than that, it's very important to get it. And in fact, we have done studies, people have presented studies that have shown that, if you don't screen older women because you think they're going to die of something else, they actually die of breast cancer more frequently than women who do get screened. So, many 75 and 80-year-olds are vibrant and productive and healthy, so they need to get screened. But it is important to remember that the American College of Radiology, the American College of Surgeons, the American College of Breast Surgeons all recommend screening screening mammography starting at age 40 every year until your life expectancy is 5 years or less. And your sorority is a Black sorority. So there are things that you have to know about that are really different in the Black community. And it's important to realize that Black women actually get a different kind of breast cancer. They get breast cancer younger. So Black women, so the American College of Radiology recommends to start screening earlier in African American and Black women because breast cancer starts earlier in Black women. And it's also important to remember that Black women get a more aggressive kind of breast cancer more frequently, called triple negative breast cancer, the kind of cancer that women with genetic mutations get. And they also have a much higher death rate from breast cancer. So I told you that the death rate from breast cancer has gone down 40% in the past 2 decades. It's actually gone down more than that for Black women. However, the disparity between Black and white women in breast cancer death rates is enormous. Black women die 40% more frequently than white women as a result of breast cancer. And now, recently, studies have shown that Black women have a much longer delay from the time of diagnosis to the time they begin therapy. So as a Black sorority, it's very important that we talk about the health disparity. We try to understand why that is, and we try to impact and really change the poor statistics of breast cancer in Black women.
Thank you so much. You actually already answered my next question. I was going to ask you about racial injustice and how it impacts breast care. Is there anything else on racial inequities that we should discuss tonight? I mean, I know my lawyer background is always oriented towards thinking about what's in unequal and justice. And You know, we often think about the issues of racial justice in the context of police brutality, in the context of educational inequities. I mean, I dedicated a fair amount of my career before this to dealing with the educational side of this. And the news, for some reason, is not focusing as much on health disparities, particularly in breast cancer, but they're real and they exist. And I was wondering if maybe you could mention the study out of Chicago and talk a bit about why there are such disparities and what we here tonight might be able to do to maybe close those gaps, including clinical trial participation and other things.
Yes, absolutely. So thank you for, so first of all, Black women get screened less frequently. And that is really the low-hanging fruit. Why that is probably very multifactorial. And I think the reason of the disparity in death rate is also multifactorial. So, it's important for Black women to be aware of the critical nature of screening to find early curable breast cancer. In addition, I mentioned to you that Black women have triple negative breast cancer much more frequently. And what that means is some breast cancers have a receptor on their surfaces that we have targeted drugs for that are very effective. If there is an estrogen or progesterone receptor, we can give drugs that block estrogen and stop the growth and in fact causes regression of these tumors. If there is an epidermal growth receptor called HER2, we have a really effective drug called Herceptin. But if you have triple negative breast cancer, you just kind of throw poison at this cancer without targeted therapy. So we need targeted therapy. And with moving medicine all towards personalized care, we have personalized therapies, which are results of clinical trials. But one of the challenges of clinical trials is including and accruing and having Black women participate so that we can find these really important personalized therapies. But if Black women don't participate in these clinical trials, then they're not going to we won't have the data to understand what the most effective therapy is. Now, there's probably very strong reasons, cultural, historical, why Black women don't participate. There is a long history of well-deserved distrust among participation in clinical trials. Things like Harriet Lacks, things like Tuskegee. But it is important for Black women to realize that if they don't participate in clinical trials, we won't be able to apply personalized medicine because we won't have the information that we need to get the targeted therapy for this population of women who actually have different kinds of breast cancer. In addition, it's been shown that care isn't care isn't care. So in the 70s in Chicago, the death rate of breast cancer in Black and white women was the same. But then they found a huge and increasing disparity in the death rate. So there was an excellent trial that looked at what happens if you give Black women excellent care, right? Not delayed care like we're finding, but if they go to centers of excellence and get not just baseline care, but excellent care. And they found that they could obviate, they could eliminate the differences in death rates where women access the same quality of excellent care. Now, women who are socioeconomically disadvantaged don't have that access. Women who don't have health insurance don't have that access. So these are things that we must make available to every woman so that they can get the optimal care that they need to have early curable breast cancer. And also the American College of Radiology now categorizes all Black women as higher risk, requiring screening beginning at an earlier age with more intensive screening. As a result of the younger age, the more frequent triple negative, the higher percentage of women who present with node positive disease who are Black.
Thank you so much. I want to shift gears a little bit and talk about breast care in the age of COVID. This is a new hot topic. There's so much new stuff going on in 2020. Actually, somebody who I care about very much sent me a meme recently who said, and the meme was a cartoon that said, 2020, do not recommend. So we have a lot more to talk about because in 2020, a lot of things happened that changed the face of breast care, including, surfacing racial inequities, which is critical and very important. But also this new virus that has been drastically changing our lives in so many ways. And frankly, the landscape of breast care this year alone has been very up and down. A lot has changed in the last 7 months and gone back and gone back. So if you could talk to us a little bit about the history since March, and then also where we stand today and the projections for the future because of what's happened, I think that would be great.
Absolutely. So in March and April, there was almost a 90% reduction in screening for breast cancer. We stopped screening for breast cancer. We couldn't screen for breast cancer. We didn't have the resources. We couldn't take care of patients with breast cancer. We actually put off taking care of women with breast cancer using drugs instead of surgery for some time. Our hospital beds were filled with patients who had COVID-19. Our ICUs were filled. We didn't have enough blood. We didn't have the infrastructure to screen women, and the country was on shutdown. So for 2 months, there was an almost 90%, as I said, reduction in screening for all kinds of screening, breast screening, colorectal screening. And then we opened up, and many women are still afraid to go get their mammograms. But it's really important to realize that the breast centers that have opened have made a commitment to safety, to deep cleaning, to social distancing, to limiting the number of people at one time. But it's really important to understand that COVID doesn't just kill people from COVID, it kills people from breast cancer. And now the estimate is that there will be, in the next decade, 10,000 additional people will die as a result of delayed cancer diagnosis from lack of screening in the time of COVID. So yes, we really did have to stop screening. We had to do unthinkable things, not operate rapidly on women with breast cancer, but that's past. And now we are confronting the fear of women going to get their screening because of the fear of being around people, going out of their home. But they should not be afraid of that. They need to get their screening. They need to wear the masks. They will likely get checked for symptoms and a fever before they come into their facilities. Some facilities will, particularly suburban ones, will ask women to stay in their cars to call when they get there, and will call them in one at a time. There is extended cleaning and deep cleaning that goes on. So everyone who takes care of you will wear a mask. I know at our institution, we now are required to wear eye coverings every time we speak to patients. And that's probably a good idea for you as well. Leave your contacts at home and wear your glasses. So there is a very safe way to get screened for breast cancer with mammography and ultrasound in the time of COVID. And we know that the cancers that we're finding now are larger and later, and will continue to do so as a result of decreased screening. So the Brem Foundation has a pledge on their website to not skip your screening mammogram this year, because there is a very deleterious impact of not getting your annual screening.
Thank you so much. I'm actually so happy to say that we're getting a slew of really good questions in. So I might stop asking you questions directly, transition to those questions with a little bit of background about the Brem Foundation, who we are, what we do, and then we'll go from there and take as many questions as we can tonight. If you do have questions, you should write them into the Q&A box. I'm actively watching them, and they are great questions coming in. You will also see some really important links coming in through your chat. So be sure to check those as well. So who we are and why we're doing what we're doing. As you heard before, I'm Andrea Wolf. I'm the CEO of the Brem Foundation. The Brem Foundation is a 501c3. We're a nonprofit based primarily out of the Washington, D.C. area, but we've recently shifted all of our work to digital, which is why we're with you tonight on the West Coast. So I would say we are often national. We maximize women's chances of finding early curable breast cancer in 3 ways. We do it through education, access, and physician training. The education is based on this idea that breast cancer is a really well-marketed disease. You'd be hard-pressed to find anyone in the United States who hasn't seen or doesn't recognize the pink ribbon. And yet with all of that information, most women don't know their basic risk factors, any screening options beyond a mammogram. And you were actually the beneficiaries of our classic educational program tonight. We do these programs in front of a very wide range of audiences, both large and small, young and old, of every shape, color, size. So we pride ourselves on bringing accurate information, primarily because of our Chief Medical Officer, Dr. Rachel Brem, to a very, very diverse group of women. But we also know that education is only as good as the tests that a woman can access. And so we build on those educational opportunities by providing some of the most innovative access programs that any breast cancer organization is doing. Our 2 primary access programs are Wheels for Women and the B Fund. The B Fund actually pays for lower income women's diagnostic tests when they can't afford them. Most people don't know that screening mammograms are generally free. But you also don't get a cancer diagnosis from a screening mammogram. You get the knowledge that something is abnormal or not abnormal. If you have a reading that shows that something's abnormal, then you need a diagnostic test. Well, those diagnostic tests are not free. And oftentimes, even people with insurance can't afford them because of copays and deductibles and other cost-sharing requirements that make them prohibitive. So the Brem Foundation provides funds through nonprofit partners reaching communities of need to fund those diagnostic tests. Now, this year, we actually expanded on that and created the COVID-19 Brem Emergency Initiative. And we were really focusing on women who had lost their jobs or were in particularly difficult financial situations because of COVID. We are very proud that we, distributed a lot of funds to help those people. Obviously, though, there is still an enormous need. The other access program that we run is called Wheels for Women. This is a partnership with Lyft because we realize that the tests themselves are not the only barrier to care. We did some research and saw that transportation is actually a huge barrier to care for a lot of women who can't afford it or don't know how to access it. And so through this partnership, we offer free rides to and from breast care appointments to women who cannot access transportation in other ways. This is the only dedicated cost-free ride-sharing program exclusively for breast care in the country. And it has really taken off. We started it in May of 2019. We had to pause it briefly in March, and then it started back up again, I believe in June, and demand is very high still. The program is primarily run out of the DC area, but we are hoping to expand that into different areas of the country whenever we can. And finally, the Brem Foundation has a very unique physician training program. The fellowship, the breast imaging fellowship at GW, is the only breast imaging fellowship in the country that teaches radiologists who want to specialize in breast imaging, not only about the most cutting edge techniques, the most advanced technologies, but also has a mandatory community service requirement so that younger physicians going out and starting their careers are trained in and oftentimes make a lifelong commitment to doing outreach beyond the patients that are already in their offices. And this makes a huge difference because you can imagine that each physician touches thousands of patients over the course of her career. And so this training really has a profound impact across the whole country. With that, I do want to say that, you know, we know that time is an incredibly precious resource, and we are grateful for your time this evening, but we are also in need of financial support as well. Every dollar matters. We would be very happy to provide a list of what different donation levels can purchase for women in need. And we would really appreciate any type of financial support that you're able to provide for us. If you look in your chat box now, there is a link. And we would also be more than happy to talk to you afterwards about different levels of financial support. And with that, I do want to also say that I am so grateful for your interest tonight, for your support in many forms. And I want to take the next 15 minutes to answer the questions that have been coming in. So the first question says, thanks for sharing your stories and providing this information to us. Can you share what type of genetic testing can be done when a woman is diagnosed with breast cancer to determine the risk to her children, whether they're female or male?
Thank you. So not all breast cancers are genetic breast cancers. A small percentage are, but we have an ever increasing number of genetic mutations and what their significance is for risk of breast cancer. So it is a blood test. It can even be a swab of your cheek. And that is sent off to one of a number of different companies. One that the Brem Foundation is partnered with is called Color, and they can give you a battery of different genetic mutations. It's best if you do this in conjunction with a genetic counselor, because we have many new mutations that are constantly being identified, and what their significance is can be different. So, and again, it can come from your mother, it can come from your father. Not every family is an obvious family that has a genetic mutation. In some families, every woman in the family has had a history of breast cancer. But in some, there are very few women in the family. And, you know, they may be small families, and therefore they may not know. And in fact, men who have these mutations, particularly a BRCA2 mutation, are at substantially increased risk and should be screened for breast cancer as well. So it is a genetic test that is done by a number of different commercial laboratories that will give you a battery, and each battery, each company does a different number of tests, but it's probably best done in conjunction. It's not probably, it is best done in conjunction with a genetic counselor, so that you can understand what these gene mutations, should you have them, mean.
Thank you so much. Somebody else wants to know, if so many different things act together to cause breast cancer, can it be prevented?
So there is no way to prevent breast cancer. There is nothing that I can say, if you do this, that, and that, you will not get breast cancer. But it is important to do a combination of things. One is to get screened, and the other, and I'm sure this will resonate with your extraordinary sorority, which is that you have to learn to be your best advocate. That I can't tell you how often I see a woman, so frequently a Black woman, who comes in so young, child in tow, and she says to me, you know, I've been feeling this mass for a year, and my doctor has told me that I'm too young to get breast cancer. And so I say to you that nobody knows you as well as you know you. And if you think something's wrong, even if a well-meaning, well-educated doctor tells you that it's okay, go see another doctor, advocate for yourself. Because at the end of the day, doctors, like everybody on this call, like everybody on this earth, is human and fallible and well-meaning, but can make a mistake. And if that's the case, they still go home and have dinner with their families, and these beautiful young women have to suffer the consequences. So if you feel something, if you see something, if you are not satisfied with the advice that you got, go see someone else. Advocate for yourself. You are empowered, important women, and you must do that.
Thank you so much. We got another question that reads, many of the healthcare providers won't allow a mammogram at age 40 unless there's a history of breast cancer in your family. What advice can you provide in that regards?
Okay, so that's a great question. So you have to realize that the Affordable Care Act, ACA, has screening tests with no copay and no deductible. And my center is not this way, but most breast centers do not even need a referral from a doctor. So you call, you go to the Brem Foundation website, you find the Centers of Excellence, and you call them and see if you need a referral. And if you don't, you march up there, make an appointment, and get your screening mammogram. And a screening mammogram is free, no deductible, no copay.
Thank you. In a similar vein, somebody would like for you to share how one can go about asking for screening when they are younger than the recommendations. Oftentimes, younger patients are told to wait, as you just mentioned.
So everything is a risk benefit. There is a very small amount of radiation from a mammogram. You get more radiation flying from where we are to where you are, round trip, twice, than as a result of being closer to the sun than a mammogram. But that being said, younger tissue is more susceptible to radiation. So there is now increasing research looking at screening ultrasound for younger women because ultrasound has no radiation. And it's important to realize that there is a downside. You know, you may get a false positive. You might need a biopsy that shows benign findings, but that's all right because a breast biopsy should be minimally invasive and should be like going to the dentist. It doesn't require stitches. It's often done at lunchtime. And I'm not minimizing it, but I'm just saying you shouldn't be scared of it. So, you know, getting a mammogram under the age of 40 is for those women who have a first-degree relative with breast cancer, meaning a mother, sister, or multiple second-degree relatives. However, you know, if you do feel something, there's a difference between a screening mammogram and a diagnostic mammogram. It doesn't matter if you're 25. If you feel something, if you think something's wrong, get a mammogram.
Thank you so much. And I actually would like to end with a non-question. Somebody who will remain anonymous said, I was going to skip this year because of COVID issues, but guess what? I will be getting my screening this year. And I want to thank her for being a model for everyone else. If there's anything that you take away from this and that you share with others, I would like for it to be that you should not skip this year. I don't want to end with a scary stat, but there is modeling being done that's going to show that because of skipped screenings, over 10,000 people are going to lose their lives to cancers who otherwise wouldn't because of skipped COVID-related screenings. So don't be in that group. Take the pledge or don't take the pledge. Do whatever it takes. Just do it. And please encourage all the women that you love to do the same. I'm sure all of you can think of at least 5 women that you love who aren't here with us tonight, and tell them, share with them what you've learned and what you've heard, because it really will likely save somebody's life who you know and love. With that, I'd like to invite Ebony back on, and I want to say a huge thank you for sharing your evening with us.
Oh my goodness. Thank you. Thank you. Thank you so very much, Dr. Brem and Andrea, for this powerful information and your phenomenal work and outreach with women in your community. It's just incredible. And I just want to thank everyone joining us tonight. You could have been anywhere this evening, but you were here with us because you realized that this information is so important. And I just want to say thank you once again. Have an incredible evening and good night, everyone.